Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thanks the organizing committee, especially Prof. Ahmed Al-Askar, and to be last speaker after all this excellent presentation. I don't know what I can add. We'll see. Inshallah. Okay, and thank you for the kind introduction. Um, The outline of my talk will be the potential of precision medicine in thalassemia, the prevalence of gene in thalassemia, natural history and pathophysiology, just titles. Then we put summarized the challenges in the diagnosis and the treatment as cases presentation. Problems and challenges sometimes not solved completely in the clinical trial. Chronic pain, it's common in thalassemias like sickle cell disease. Is there novel to improve the quality of life for thalassemic? Is there a novel stem cell for for the neonatal hereditary blood disease and the importance of prevention? Everybody would like to go for precision medicine, especially chronic diseases and thalassemias and hemoglobinopathies really need wellness vision. Improve equality in both diagnosis and treatment. It's a comprehensive, it's a holistic approach, and improve the outcome of the patient and patient satisfaction, happiness, and have normal life. I add to wellness vision, it's treatment for all, because these days start to be treatment not for all. Early detections of disease risk, solve the challenges, which is really important, prevent disease complications, keep the patient out of the hospital, and the safety of any medications, tolerable safety, and satisfaction of the patient. No relevant disclosure. Here, just the map to see in Saudi Arabia, there is different areas. And if you look to Jeddah area, we have around 40% alpha thalassemias, beta thalassemia, lesser, and E, and other hemoglobinopathies. Here, like, because we are in Jizan, it's unfortunately, it's the highest of inheritance for beta thalassemia. So I'll hope next year with our programs will be, this prevalence will be changes. Thalassemias decrease synthesis. And really here, I would like to put for our area alpha thalassemia, we have it's different alpha thalassemia than Far East. We are luckily we have the prevalence of silent carriers and alpha plus. We don't see, we have some areas more than 40% alpha thalassemia. We have H disease in our area. We don't see much like stillbirth. This is the one I would like to put attention, because really I will go with you with cases for diagnosis, challenges in diagnosis and prevention. Like here, like beta thalassemia major, there is no A, but should be a clinical, ask about the clinical, they require transfusion less than 2 years. This is nice to see how a free alpha chain can cause all these problems. I summarize the natural history and the treatment of thalassemia in these pictures. And I add, like, if you don't have treatment, what will happen to the patient? Transfusion complications of iron overload, the oral chelations, and the stem cell gene therapy. And there is a novel for pediatric and a novel for hemoglobinopathies. All the time, we need to look for the goal of iron chelations. like safety of the tissue ion, and the other thing, acceptable toxicity. All the time we have a lot of novel researches and novel treatment, but look for acceptable toxicity. And the most important for the all goal of ion chelations is prevent stress oxidative damage, because this is affecting all organ. Challenges. Thalassemia, because it's a chronic disease, have a lot of challenges. So all the time, availability for diagnosis. Some of the patient, they don't have even the diagnosis. They don't have the eligibility for the treatment. They don't have like enough available blood transfusion for them. So the trend was before for increasing the splenectomy complications, and now about more and more we can see about the quality of life for their patient. Just I will go quickly for challenges in the diagnosis, premarital screening. All the time I put this picture because I kept seeing more and more unfortunate. This is my patient, the groom. He is thalassemia intermedia. He want to marry. This is his bride, and this is her CBC. Her CBC, if we put it in the exam and all the time, we need to keep it in mind. The patient is look like mild anemia, microcytosis, and the patient hemoglobin electrophoresis is normal. So the things like, if we look to this, I put mark to see, is this marriage is compatible or not? What your answer? Most likely what you'd like to say, yes or no? Thank you so much. Yes, it's very simple. If we look for RDW, it's high. So it's really iron deficiency anemia. This is why hemoglobin A2 wasn't high. So this marriage, unfortunately, it's not. And they get married, and they have 4 thalassemia daughter, okay? And they have the complication later. This is study long term. Just when we start, we look what the survival and the disease complication. I put this study for 14 years retrospective to see what the cause of death. It was 2 causes, because that time only we have this feral injection. So the cardiac was in younger teenager, iron overload in the heart, and second one, the infection in children, they are splenectomized. Challenges in the diagnosis, like is serum ferritin accurate assessment for cardiac iron overload? And this is a 15 years old boy. He was treated while he was child, thalassemia transfusion dependent. He presented lated with intermittent claudications. Growth parameters were normal. Mean serum ferritin less than 2,000. Cardiology assessment normal. So we sent him to Royal Free Hospital for MRI to start in 1995. So if we look to the picture with the arrow, big difference between the two, and then we get the result. Why he had intermittent claudications? Because severe iron overload, so has been treated with oral chelation, and he is fine. Now, compatibility and availability of a blood transfusion. Thalassemias, its problems and challenges because over the years. The more they are growing, the more there is a problem. If we look here for this thalassemia major patient, she is phenotyped properly, she is giving screening well, giving blood, no antibodies. During 2 years, she received 43 units. And if you still look, her hemoglobin, it dropped to 6 and 7. So availability of transfusion, until now, there is no artificial blood transfusion. We face it in some patients. Challenges in iron overload. This is a patient, he presented, he's excellent, he is compliant, is good with XJADE. His serum ferritin is 578, which is excellent. He is all the problem complaining of chronic fatigue syndrome. He is the one highly educated, graduate from the state, he is working, but he said, when I'll go to the work, really like every single of my body, like I'm pushing myself for work. He's smart. When we do MRIT to star, he's severe liver iron overload. Okay, this is another girl, thalassemia major transfusion dependent. She is followed in private hospital. She's all the time, her serum ferritin very high, around 7,000. She's on XJADE. When we ask her how you should take XJADE, she stuffed the a tablet, so without drinking much blood. So unfortunately, when we do her MRIT to start, it was severe iron overload. But unfortunately, the hair physician in private hospital decided to remove the spleen because the spleen can solve the liver iron overload, doesn't make it worse. Here the patient, I change her from XJ to Jadinu, and for her, I put her on 3 times dysferal. If we look for her MRIT to start, markedly from severe to moderate. But the patient, she wasn't happy with like injection of dysferal. And Jadinu, it's not enough for her. Thalassemia intermedia, please don't treat thalassemia intermedia like thalassemia major. This is a patient, he had, if we look to his diagnosis, just if we look to the diagnosis, his electrophoresis like thalassemia major. But if you go to the history, over 14 years only he had 8 times transfusion. So please don't go with electrophoresis history, very important. This patient, his serum ferritin is 1,500. He has a problem with severe iron overload in the liver. This patient, unfortunately, he's died 2 months ago with pulmonary hypertension. This is a young patient, thalassemia intermedia. Unfortunately, she's splenectomized. She was well until she became at 20 of her age, start to require more transfusion after she get married. And unfortunately, her platelet count higher 1,000,000. And she had abortion, and she presented to ER with hemoglobin 5. Before, no problem. And she had like moderate iron overload. So thalassemia intermedia, it's naturally different from thalassemia major. We need to consider that. And if you look to your centers, we have a lot of thalassemia major still alive. Thalassemia intermedia, unfortunately, they have a lot of complication, morbidity very high. So we recommend all centers, anybody to treat thalassemia, they should have MRIT to start routinely for follow-up. Okay, is splenectomy increase the risk? Just one study, like here, the patient splenectomized all the time. Everybody loved to remove the spleen. It was a trend, alhamdulillah, change. This patient, the idea is if you remove the spleen, you remove the iron with it. If you remove the spleen, you minimize the transfusion. Let's see this patient, 34 years, E beta, thalassemia intermedia, the platelet 2 millions. And this patient, she had frequent blood transfusion before. To certain age, this thalassemia intermedia, she become requiring a lot of transfusion. If you look for each year, because she come with very low hemoglobin, and he had iron overload very severe. Her platelet sky high, her hemoglobin with in spite of all transfusion markedly down. This is see how much she is receiving. Another patient, Okay, splenectomized, splenectomized, more transfusion, more abortions. Okay, so really, in spite, if you do all the phenotyping, giving good blood, they required a lot of transfusion for certain age. This is as a summary of her transfusion before, no problem. When she get like on 20s, she had more complication with the sky high platelet and abortions. 38 years, the same, but his serum ferritin wasn't high. It's the same. He had like iron overload with MRIT to start. So conclusion, splenectomy does not minimize transfusion, does not prevent anemias. It's accelerate the hepatic and cardiac overload. Splenectomy. Can we avoid splenectomy? Yes, we have this study over 17 years with hydroxyurea, do good job, but you need to be very patient. Endocrine complication. Did we get better? Let's see, in our studies, we have a lot of a study on endocrine in our center with collaboration with international network of clinician endocrine. What we found, pediatric and adult, there is increase in endocrine complications. I will not go through because we have another message. Start to have seeing more of glucose dysregulations in our patient. I will skip all this. Okay, chronic pain. Chronic pain we presented in 22 in EHA about chronic pain for thalassemic major, and recent study has published with Journal of Applied Hematology. What we found, it's a problem for the patient, and some of them, they are in narcotic. If you look for quality of life, tell me, all of the quality of life is very bad, and it's unfortunate. So it's not only to give medications, you need to have normal quality of life for your patient. Okay, so conclusion, chronic pain is common. It's a major problem. Unfortunately, it wasn't addressed well. Analgesic, narcotic, it's not the ideal. There is a solution for them? Is there a novel therapy to improve the quality of life and chronic pain for thalassemia? This patient, he is like 38 years old, thalassemia intermedia. He has a major problem of shoulder pain. He said, even I cannot eat, and back pain. So referred, we have in our center wet cupping clinic. It was established in 2012, and he referred for this severe pain. And also he had a frequent transfusion like thalassemias. If you look in a year, he received too much transfusion lately. So after a cupping, he markedly improved. But what we see after cupping, so even we try his requirement for transfusion decreased, his serum ferritin decreased. The amazing this one. Look to his like iron overload in the liver. All our study, it's done in Netherlands, because we don't have a software, unfortunately, recently. So that the MRIT to start in our hospital, we send the result to Netherlands to read it. If you look to his liver, from moderate and become normal after 3 cupping. So this is a great news. This is another patient. He has a major problem with increased liver enzymes. He had vitamin D is low, in spite he is in oral drops. What we found after cupping, because of severe back pain, he is a young chap, he is like working for the family. We try, if you see his serum ferritin, from 4,000 to 3,000 from one sitting, and severe iron overload of the liver. The amazing, if you look to the figure here, after the first cupping, what happened to the patient? There is immobilization of the liver. I didn't tell in Northern Land. They said, what invasive you are doing? It's like if you look for the scan is completely different. Okay, so this is a patient, marvelous patient, young patient, thalassemia major. All the time, her menarche stopped, and she had a chronic fatigue syndrome referred by her OB-GYN. She had severe iron overload for the liver, liver enzyme is high. The amazing, after the first cupping from 8,000 to 4,000. So it's a marvelous, for me, like I found really should be all center trained to do cupping. This is the first paper we published. See, all the diseases has been referred to cupping therapy in our center. Okay, we found cupping has improved the brain, removed the iron overload from the liver, improved the anemia. So, is there any further study for cupping therapy? Yes. Okay, now we'll go with you with this is a study to see chronic in our center. Unfortunately, the majority of referral is pain, headache, infertility, allergic, autoimmune, okay? And improve the quality of life. This is a study, it's amazing. Would like to know why this cupping therapy improve the quality of for pain. This study has been published in Oxford Academy, and what we found, all the inflammatory markers markedly down. There is 17 interleukins, new interleukins. They are waiting for us and will be maybe a Nobel Prize. This is the result. How after cupping, there is markedly improvement in inflammatory markers, and there is 16 interleukins, a natural killer. Okay? So wet cupping, this is from Academy, shows wet cupping remove oxidant and decrease oxidative stress, this is what we need. Okay, this is a clinical trial has been, I'm part of it. What we found in this one, we found like immunity markedly increased for thalassemia patient, this one children. It's a clinical trial. It was addressed and registered as a clinical trial internationally. And the oxidative stress, prevent the oxidative stress for thalassemia children. And this is what I want. And this is, anybody please read. This is another pilot study, also in children, how this, it's safe to do wet cupping therapy for thalassemic children to decrease the iron overload and increase the immunity. I would like, this is another paper, please need to be in hand, certified hand to do wet cupping therapy. Wet cupping therapy, it's a treatment. What happened, the difference? It should be in epidermis. The needle, the scratch of the should be in only epidermis. If you go deeper, it's not a cupping. So should be a certified who doing cupping therapy. This is how the mechanism remove the iron. So a lot of papers, I recommend with a comprehensive care in all center. It's cheap, it's excellent result, and it's for emergency. We lost a lot of patients like you give. These viral infusions, if you start, nothing stop them. So should be certified cupping therapy clinic. We need to have the wisdom of traditional and should be impactable and a solution for a lot of diseases. This is, I was...
1 minute, yeah, Doctora. 1 minute, Prof.
1 minute?
Yeah.
Okay. Novel treatment. In Australia, they said milk of the mother have stem cell. Then start to be a lot of paper, stem cell in the milk of the mother, a lot of paper, and now they use it for premature babies, okay? And then there is a recent study from Iraq, University of Iraq, shows a randomized clinical trial how if you get a non-mother breastfeeding, it's work like a novel stem cell. So for me, if you would like to see it and see the result. Conclusions, how we can no more complication of thalassemia, preventions. This is take-home messages. Please look to this one, then do that one. Thank you so much.
Yeah.